present here. I, Dr. Snehal from the USV medical team, welcome you all for yet another interesting session in the USV CME India series, where we will be touching upon a very interesting topic, that is conflicting guidelines of hypertension, which ones to follow. Without much ado, I would now like to introduce to you our esteemed speaker for the evening. We have with us Dr. N.J. Singh, sir. Sir is a director at the Diabetes and Heart Research Institute, Bangalore. Sir is a chairman as RSSDI Jharkhand. He is executive member of National RSSDI, ex-governing body member for National API, ex-chairman API Jharkhand and CDD-SPK. Editor Millennium Book of Medicine. He is also the Associate Editor for Postgraduate Medicine 2021. He has edited monographs on COVID by ICP and API 2023. He has more than 40 national and international publications to his credit. He has been the admin and founder for CME India as well. And he also has his fellowship from WHO. Thank you so much, sir, for joining us this evening and giving us your valuable time. It's an honor to have you on board.
Thank you.
With this, I hand over to Singh, sir, to introduce our rest of the speakers for the evening.
Welcome. सबका स्वागत है. Today we are going to discuss a very important topic, that is the conflicting guidelines of hypertension, which one to follow. And you know, this is very important to all of us for all the disciplines, because many times we get lots of queries. What should be the blood pressure level and what should be the initiating drugs and other things. So today I have a great pleasure in welcoming our very learned speaker, Professor Dr. L. Sreenivasamurthy, and we also have the two panelists, Dr. from the Northeast, Diabetologist, Dr. Noni G Sigha. I will just introduce. He is the postgraduate program in diabetology, certificate course in thyroidology and hereditary IMA bulletin in Journal of Assam. He has lots of things he has done in the Northeast. Also editor of the Northeast Diabetes Society Update. That is, he edited a very excellent book on the diabetes itself. That is also available for the download. And he is a very brilliant physician, as we have seen in from his comments in the CME India group. And the second, I welcome Dr. Sangram Biradar. I think he is a great person, MD, FICP, FACP, FRCP, and FCSI, FACC, USA, former professor of medicine, MR Medical College, Gulbarga, Karnataka, and also the associate editor of API Karnataka Journal. A great player, sir. He is also governing body member now of the National API. So great personalities. And I think Dr. Noni G Sigha, please introduce again our learned speaker, and then I hand over to you, Dr. Noni.
Good evening. Thank you, sir. And I'm really thankful to the CME India and the USV for giving me this opportunity. And I think this is a very nice, interesting talk. And we know that the hypertension itself is a major concern in India. And I'm hunting around 30% people are suffering from hypertension. And most of the diseases like cerebrovascular disease, stroke, myocardial infarction, and chronic kidney disease, the hypertension is the main important cause. And we're going to target this hypertension. And to reduce this morbidity and mortality, the many guidelines has come up. So we know that JNC and the STCAHA and Indian Society also there of hypertension, RSSDI. So many are there, but sometimes it becomes very confusing. And the guidelines on the different how to diagnose hypertension, what are the gettings of hypertension, what should be our targets, and how we should weigh for it. So a common physician becomes very confusing which one to follow, especially in the Indian context. So clear these doubts and the best one, and we know from the topic that conflicting guidelines which are to follow in hypertension will be the talk will be delivered by already been known to that Professor Dr. Sreenivasamurthy, and he is a very learned and he has a lot of, you all know him very well, and is a very good speaker and got a sound knowledge on the subject. And he is quite known, but still for the few new people maybe joining us. So for them, I'll just say a brief note of Srinivas sir. He's an MD, triple FRCP, FICP, and many others are there. And life care is right now is the life care working in Hypertension Hospital and the Research Center in Bangalore. He was a former consultant at Fortis Hospital, Clinical Global and Apollo Hospital in Bangalore. Right now, he's in the post of Vice President, National RSDI. He's a Vice Chairman, FPI Karnataka. And he's a governing council member of so many like Karnataka, RSSDI, CCDSI, Indian Society of Corona Medicine and ICE, etc. And you can see that the endless list without wasting time. And he's a very learned and he's a very he has a lot of publication and he's participated more than 100 live shows. I think there's endless list. I think better to skip all this. So it is my privilege and our privilege to listen to him, Dr. Professor Sreenivasamurthy sir. So Sreenivasamurthy sir, please go ahead.
Thank you, Dr. Noni, for your kind introduction, and good evening all. It's a pleasure and a proud moment for me because we are all very proud members of CME India, where Dr. N.K. Singh sir has been doing this tireless job from quite few years, and we are all on a daily basis learning from this. My slides are visible?
Yes,
Yes.
visible, sir.
Great. So he had requested me to talk about this conflicting hypertension guidelines. Mostly we are covering the international guidelines, and whenever a new guidelines comes, now we know ESH 2023 has come. So that is where we are going to differentiate with the existing guidelines. And I do not have any conflict of interest in this presentation, except that I'm a member of CME India. That is my conflict of interest with NKS sir. And thanks Dr. Noni and Sangram sir for your contributions in the CME India, and also great job you people are doing in educating most of us as colleagues on a daily basis. And Sangram sir daily sends 2 articles from eminent journals, which is a great learning for most of us. And Dr. Noni gives, across the spectrum, he gives his comments in CME India. And of course, NK Singh is the person, the real Sutradar who takes care of all our doubts day and night. So let's move on to the topic. These are the guidelines which I'm going to touch upon: the International Society of Hypertension, the 2018 ESC, ESH, 2017 ACC, AHA, and of course, one of the Indian guidelines in 2019, which was published in 21, and of course, the latest 2023 ESH guidelines. And that is where we'll spend a little more time, but this is going to be my contents flow of definition, classification, measurements, the diagnosis part, how do you evaluate, and hypertension associated target organ damage, and the non-pharmacological interventions, which most of us tend to neglect in our routine clinical practice. And finally, the drug therapy, how do you initiate, how do you monitor them? So this is going to be little elaborate way we will discuss. So let us look at the definition and classification of hypertension through various bodies. The first one is 2017 ACC AHA, where they've told it has to be categorized to normal, elevated, stage 1, stage 2. So it looks very simple. Normal is less than 120/80, and 130/80 is elevated, the systolic only. And stage 1 is 140 to 190. More than 140/90 is stage 2. That's quite simple. And 2018 ESC, ESH. So you have a comparison now with 2023 also. More than 140/90. And there are the 8 categories, 7 categories have been there. Now it has become 8 categories, which I'll show you in a couple of slides later, where they talk about the optimal, normal, high normal. So there are 3 categories before it is actually grade 1. So grade 1 literally is above 140/90. So 160, 100 is going to be grade 2, and 180, 110 is going to be grade 3. And they have defined isolated systolic hypertension, where your diastolic is less than 90. The systolic is above 140. 2020 International Society of Hypertension, where 140/90 is the cutoff for BP, and they have got a very good classification, I would say, with high normal of 140/90, and beyond 140/90 up to 160/100 is grade 1, and beyond 160/100 is grade 2. And the most important, this is about your office BP. They have set in criteria for hypertension based on the ambulatory BP and home blood pressure as well. That's a differentiating point between the home, office, and the ABPM. So this is where is in your clinics what you get. beyond 140/90 is a straightforward grade 1. Beyond 160/100 is a grade 2. Whereas ABPM 24-hour average is 130/80 is to be diagnosed, and daytime 135/85 and nighttime 120/70, beyond which you need to treat them as hypertensives, and home blood pressure is 135/85, whereas if you see here it's 140/90. So that's important to remember. There is a differentiation clear cut, and it has all started back from 2020. Now the Indian Guidelines of Hypertension, wherein it talks about 140/90, which is similar to the International Society also, where the optimal, normal, high normal are there: 140/90, 160, 110, 180, 110. So there are 3 grades. And in the isolated systolic hypertension, they have divided into 2 grades. That is 160/90 and beyond 160 is they've again bifurcated isolated systolic hypertension. Now this is the latest ESH guideline, where they've got about 8 categories. That is what makes us little confusing. Again, there are 3 grades of hypertension: 1, 2, 3, grade 1, 2, 3, 140/90 and 160/100 and beyond 160/110. So it is again 3 grades divided into. And isolated systolic hypertension, there are 140, the systolic hypertension, beyond which below 90 is the diastolic. And similarly, isolated diastolic hypertension, for the first time they have defined as diastole more than 90 and the systole less than 140. So this is something which is new, which has been highlighted. So what are the latest guidelines have to say? This is to summarize. This one slide talks about your ESH consensus guidelines, which talks about the 8 categories, which I showed you in the previous slide. So this multiple categories mimics the biology, but may complicate implementation, and to bifurcate in routine clinical practice may be difficult. That's why I highlighted that point. CVD risk, they have classified into high, very high, and established CVD or CKD. Long-lasting or complicated diabetes, again, they've included this. Severe, the end organ damage. Markedly elevated single risk factor. All others, that is assessing the risk using the scores system which they have implemented. And what is the comment about this CVD risk stratification is, this is a broad list of risk indicators with many based on clinicians' judgment. So this is going to be subjective. And that is where we again might get into trouble, because we may not calculate just like other fellow physicians. Now the diagnosis part, what they have told, though there are 8 categories, we need to take the average of last 2 of the 3 accurately measured BP readings with presumed hypertension confirmed by at least 1 additional set of office BP, unless initial BP is very high or the CVD risk is very high. That means the home blood pressure monitoring has to be substantiated with 1 additional set of office BP. So the role of anti-hypertensive medications for diagnosis not specifically mentioned here in this category. Now, this is the other ones, which are recommendations strengthen previous ESH guidelines. The below ones are out of office BP, that is ABPM and home blood pressure monitoring, lifestyle intervention, initiation of anti-hypertensive medication. The age group is 18 to 79 or 80, you can say. Above 80, 160 and 140 can be considered. In frail patients, individualized treatment. These are all mimicking our recommendations, which are similar to the previous ESH guidelines. That is why I bifurcated these segments. And the treatment of BP targets, again, 140/90 for most of our age groups, that is 18 to 80, we can say, is to keep the target below 140/90. And if the treatment is well tolerated, the target can be as tight as less than 130/80, but not to bring down, like the previous, they have told, below 120/70, please do not bring it down. And that's something there. So this is a very clear-cut differentiation, what I'm showing you. This is what is the new, and this is what is the old ones they've carried out in ESH 2023 as well. Now let us look at the bifurcations of the level of evidence based on the BP, the optimal, normal, high normal, all the 8 categories is a level 1 indication, that recommendations where the definition of BP categories and hypertension grade and stages according to office BP, where you can see this in addition to grading of hypertension, which are based on the BP values, it is recommended to distinguish stage 1, 2, 3 hypertension. And that is, stage 1 is uncomplicated hypertension without evidence of end organ damage, diabetes, CVD, and without CKD, that is beyond stage 3. So this is called stage 1. And anything like presence of diabetes itself, irrespective of the damage or not, just being diabetic itself pushes them to stage 2, and CKD stage 3 are evidence of end organ damage. And of course, the presence of established CVD or CKD, that is stage 4 or 5 CKD, makes him into stage 3. So this is a new thing which has come up, where based on the irrespective of the BP values, also you need to consider the associated comorbidities and categorize them into staging of stage 1, 2, 3. Very important, because stage 2 and 3 you need to treat, and the target has to be a little tighter. So to compare these, the ACC-AHA defined the stage 1 hypertension as 140/90. The ESH, ISH, and the Indian guidelines which I was talking about talks about 160/100. So that is something to remember. So this is the comparison when it comes to the definition of these 3 or 4 guidelines. Now let us look at the measurement of blood pressure. What are they going to talk about? The measurement has to be, of course, in the office BP for diagnosis and management of high BP. The proper methods, technique has to be taken care. And this is a word of caution to all our colleagues that you need to keep at least 2 sizes, the large adult and the regular adult size. Please do not take, the BMI is high, we need to use this large adult curve. That's something we need to keep it in our clinics. So let us look at what are the clinic, the home blood pressure, and the ABPM readings. That is the out of office BP when you measure. So in the clinic, 120/80 equals to the home blood pressure of 120/80 also. These are the corresponding values which we are trying to show here. The ABPM also, the daytime would become 120/80, but the nighttime would be 165, and average 24 hours would be 115/75. This is something too important to remember. So this is the third one. If you concentrate, 140/90, which corresponds to 135/85 at home and 135/85 at the daytime, or 130/80 at 24 hours ABPM. So this differentiation we should know in our routine clinical practice, because at this stage you need to intervene with the treatment options. So that's something all of us should remember. 140/90, which corresponds to the home blood pressure, is always lesser because they are in the familiar environment. So 135/85, 160/100 corresponds to 145/90. Now let us look at the advantages of ABPM versus home blood pressure. Of course, ABPM can identify and differentiate white coat or a masked hypertension. It has got a prognostic value. Nighttime readings, which can never be done in any other method, can be picked up with our ABPM, and it gives you a real life setting, literally mirroring the daily ups and downs of your BP. And prognostic BP phenotypes, abundant information from a single measurement session can be there. And that is something, BP variability, what we call glycemic variability. Similarly, BP variability can be easily picked up with the ABPM, but of course, it is limited availability and resource setting. In a tight resource setting, it's difficult, expensive, and can be uncomfortable for many of our patients, but we need to educate. And I make it a point to hook ABPM to all our newly diagnosed, especially below 50 years. I make it a point mandatory that ABPM has to be measured with all our young hypertensives. Of course, the home blood pressure can identify white coat and mask just like your ABPM. It is cheap and widely available. Measurement in a controlled environment, familiar environment like a home. Patient engagement in BP measurement is there fully, easily repeatable, and used over long periods to assess day-to-day BP variability. Still, you can get much information in our cost cutting circumstances. The only disadvantage is it's a static BP and potential for measurement errors if you don't enlighten the patients or the relatives about the proper tying technique, sitting, taking rest, discarding the first and then taking the second measurement as always. And of course, nocturnal readings cannot be made out with the home blood pressure monitoring. Now let us look at the comparison of values in the ESH guidelines. The ambulatory BP and the night and 24 hours are similar to your ISH also. So essentially, when you compare these guidelines, the ACC, AHA, ESH, ESC guidelines advocate the use of out-of-office BP measurements for confirmed diagnosis. And the ESH, ESC guidelines have also clearly outlined the benefits of ambulatory and home blood pressure monitoring. This is what we should learn, that by comparing all these guidelines, the advocate or encourage the use of out-of-office BP measurements even in our routine clinical practice. I think COVID was a blessing in disguise for most of our patients to use the glucometers and the home blood pressure monitors. And that is where the huge, I would say, boost to use these in our routine clinical practices come up. Many of the patients are very happy checking there and monitoring, bringing their data whenever they visit us. Now let us move on to the next section of diagnosis of hypertension. Now, The screening and diagnosis as per ESH ESC, when the patient's BP is optimal, that is less than 120/80, based on the individualized, of course, but they recommend every 5 years you need to check. But if there are risk factors, you can always do it more frequently. There is a normal BP that is less than 130/85, repeat BP once in 3 years, high normal that is 140/90. Consider also look at the mass hypertension, repeat BP at least annually, and out of BP's measurement is something suggested at this level. Very important to discriminate and delineate these through the help of home blood pressure or the ABPM if affordability is not an issue. And of course, 140/90 when you cross, you should either confirm diagnosis by repeat visits for office BP, or you can encourage out of office BP measurements through ABPM or the home blood pressure. And of course, then you start treating the patient. What does the International Society of Hypertension talks about? Similarly, the normal BP less than 130/85, and it can be remeasured after 3 years. And high normal is 140/90, and hypertension is beyond 140/90. When there is a high normal is the area where it's a gray zone, where you need to take 2 or more readings, use the average of second and third, and it falls beyond 130/85. Remeasure in 2 to 3 office visits, and if possible, confirm with the home or ambulatory BP. Again, you can see out of office BP is encouraged for the diagnosis part, and repeated office BP beyond 140/90 indicates hypertension, particularly if the home BP is beyond 135/85 or the 24-hour ambulatory BP is 130/80. So remember these ABPM and the HBPM readings of 135/85 and 130/80 respectively. The Indian guideline talks about 140/90, very clear cut. The home blood pressure is 135/85. The ambulatory BP is 135/85, and the mean is 130/80, again mimicking the other guidelines. Now the ESH, now this is the latest one what we are talking about. What do they talk about? When it is a grade 1, that is 140/100, asymptomatic, without evidence of end organ damage and CVD, at least 1 additional office visit within the next 4 weeks, and then the diagnosis is established. Then you go with the lifestyle, drug treatment, optimal BP control, at least once in 3 months you need to up titrate. This is going to be in grade 1. Grade 2, 160 to 180 systole, 100 to 110. That means 180, 110, up to that, between 160, 100 to 180, 110, you need to again look at the same algorithm. Here, the stage 1, again, symptomatic, or sorry, grade 1, symptomatic, or just by presence of diabetes makes you a person where you need to start the lifestyle intervention and the treatment. Grade 2 and 3, obviously, you go ahead with that. And the staging, if you remember, stage 1, 2, 3, what I told about, and comorbidities are CKD stage 3 and above, established CVD, evidence of end organ damage, presence of diabetes, all these, again, with a grade 1, you continue to immediate drug treatment is a must. Remember that. Now, let us look at how do you evaluate the patient once you diagnose. So the basic optimal requirement of labs would be, this is as per ACCHA, as you can see here, the fasting, CBC, lipids, EGFR, important, sodium, potassium, TSH, urine, electrocardiogram, that is ECG, and these are optional, uric acid and urine albumin creatinine ratio. What about the International Society of Hypertension? They talk about the history to exclude drug-induced hypertension, evidence of organ damage, assess the risk stratification of CV, symptoms and signs of secondary hypertension. They talk a word about the proper history taking, which all our teachers have been telling us from ages. And of course, the lab test includes the RFT, the LFT, lipid profile, dipstick, and the ECG. Additional test is based on the patient's condition, individualized, which looks again very practical, because in the cost-cutting scenario like in our country, this is something which you can go with the basics and then go as per the individual patient. The ESC, ESH talks again of the similar category of urine analysis, liver functions they are added on, that is the difference here, ESC, ESH. And 2023 ESH, they talk about all these, including uric acid. EGFR is something which is there, and the urine analysis, where the multi-component dipstick is enough to look at the UACR or microscopic in selected microscopy in a selected patient. This is about your ESH 2023. So essentially, when you compare all these guidelines, they recommend routine labs, which includes the sugars, the lipids, the thyroid, uric acid, RFT, and calcium and 12 lead ECG in patients with hypertension. This is the basic routine with every patient whenever you suspect hypertension or you start treating hypertension. Before that, please have these baseline labs as important category to be included. Now let us look at the hypertension associated target organ damage and how do you do the risk assessment. This is very important because in our busy routine practice, we need to risk stratify whenever you diagnose hypertension or diabetes or any other disease for that matter, because you need to target their A1Cs or their BP or lipids based on this risk stratification. I want you people to categorize that, look at the moderate risk and then high risk and very high risk. The moderate risk where the calculated 10-year scoring is between 1 to 5% and grade 2 hypertension. But look at the high risk category, people with diabetes. Just being presence of diabetes apart from LVH, EGFR between 30 to 60, there is a definitive risk called high risk when you have the diabetes, and diabetes with a target organ damage, example, a USCR or a proteinuria or dyslipidemia. That is something pushes them to very high risk. So remember this, any diabetic, you need to treat them as high risk, irrespective of their comorbidities, complications, or the EGFR, etc. So treat all our diabetics with tight control, because remember, bringing down the BP will impart better advantages to our patients rather than chasing HbA1c. This is something all of us should remember. Bringing down the BP gives more CV benefits or mortality benefits versus bringing down the A1c. I'm not saying don't control the A1c, but this is something all of us should remember in our routine clinical practice. Again, I'm showing you the hypertensive stages, which I was talking about, stage 1, 2, 3. This is the y-axis, and the x-axis, you can see the high normal grade 1, 2, 3, which is there. So just to show you a comparison, stage 2 asymptomatic disease, where the end organ damage, CKD grade 3, or diabetes without organ damage, and if their BP is 140/90, look at them, they are into high risk. Just being 140/90 and having this is something which is very commonly seen, because 140/90 and having diabetes without organ damage or a CKD grade 3 is something which most of us encounter in our routine practice. So these are high risk individuals. You need to target them very tightly, very meticulously, you need to follow so that they don't end up with complications. So the hypertension mediated organ damage, what are the tests you need to look at? The green ones are the class 1 evidences which are existing. That is your ECG, echocardiogram, and of course the ultrasound examination of the carotid arteries, which normally we don't try to do, but that's a level 1 recommendation. But the EGFR and the USCR and fundoscopy, again, most of us have lost touch in doing this because now we have a ready-made fundus, but please get it done at a baseline and look at the changes, if at all there are in the fundus. And these are the basic, with 4 arrows which I put. All of us can do it even in a cost cutting scenario. These are very, very affordable, even in our Indian scenario. Please do not hesitate to do at least baseline and as per the patient's yearly or 6 monthly based on the individual targets. So this is what the ESH 2023 talks about, the hypertension mediated organ damages, where I have already alluded upon the serum creatinine, the USCR, the 12 lead ECG, and of course echo they have told, and the ABIs, all these they have told, and they have given also in the table 10 the advantages and disadvantages methods to assess LVH in clinical practice. They have told echo and 3D echo and the CMR, which of course we don't do, but ECG, you can see the lot number of pluses are there. So even in a country like ours, you can do affordable ECG to all our patients. Forget about the echo, 3D echo, etc. But this is something which all of us should do at least yearly once in the background of diabetes or other comorbidities. That is the emphasis which I want to make in this slide. And this is where the ESH 2023 talks about. So essentially, when you compare all guidelines regarding the risk assessment, the guidelines are extensively classified the stages as per the BP levels associated with the CV risk factors, the end organ damage or comorbidities, they have classified extensively. And the ESH-ESC guidelines also recommend the targeted investigations to confirm and rule out the presence of target organ damage. And that's something which all of us should do it. Now, hypertension associated target organ damage and the CV risk and initiation of treatment. Now that's important because you stratify particular person into whatever stage or grade of hypertension. What do you do next? So when you tell them you are high normal with 140/90 and below, lifestyle advice has to be there, and consider the drug treatment in very high risk patient with CVD, especially CAD, if you're suspecting. So that's something very, very important. It is not only lifestyle, but if you think this person has got the high risk of patients with CVD, then you need to treat them. With grade 1, that is up to 160/90 and below 160/100 and 140/90, lifestyle and immediate drug treatment has to be there irrespective of the risk factors. Grade 2 and 3, again, immediate drug treatment is there. And the aim for BP control would be roughly 3 months or 12 weeks, you need to look at them. So in this category, in the grade 1, where up to 160/100, the drug treatment is low, moderate risk patients without CVD or without risk factors. After 3 to 6 months of lifestyle intervention, if BP is not controlled, then you need to escalate. So the general recommendations of office BP target in hypertensive patients would be 140/90 in all patients. Below 140/90, you need to maintain class 1 level A evidence. And provided the treatment is well tolerated, you can make a tight control of up to 130/80. Again, class 1 and level A evidence. Diastolic BP target of less than 80 should be considered for all hypertensive patients, independent of the level and risk of comorbidity. Level 2, that is where they have given isolated diastolic hypertension in the ESH 2023, which I was talking about earlier. In older patients beyond 65, old age, receiving BP drugs, it is recommended that the systolic BP should be in the range of 130 to 140. Below 65 years, who are on treatment, the BP range should be 120 to 130. Both are level A, class 1. So remember, this is something you need to keep in mind. So in general, if you can keep anybody's BP below 140/90, it is relatively safer. And people who achieve this target of 140/90, you can reach up to 130/80, but not below 120/70. That is all is the essence of most of the guidelines. Now let us look at when you have a comorbidities, what is office BP recording? So here, if you see, this is the first one, which you look at 18 to 65 years, which most of us encounter in routine clinical practice. So 140, this is about systolic BP. Beyond 140, all these, if you see, all are beyond 140, which is CKD, CVD, stroke, all that, which is for the office BP when you diagnose. And the diastolic BP threshold is 140/90. So somebody is 140/90 between this reproductive and the productive age group of 18 to 65, you need to keep it below 140/90. And the systolic BP, what is the target range in all these comorbidities? Diabetes, CKD, CVD, stroke, or diastolic BP. You can see it is 130, except in CKD, where it is 130/140. Between 130 to 140, if you keep in CKD, which we know in routine clinical practice is very difficult to control BP in such circumstances. So up to 140 is also fine. So the age group of 18 to 65, which most of us encounter, if you keep below 130, it is fair enough. Up to 120, not below 120, and keep the diastolic BP below 80, not below 70. So this is all you should remember. 130/80 would be ideal in most of the settings. 2 to 3 weeks for lifestyle, then pharmacotherapy if needed. Beyond 4 weeks, BP should be recorded in both arms, in lying and standing before initiation of pharmacotherapy. Stage 2, 3, a shorter waiting period is required, and you can initiate treatment immediately also. In those who have evidence of end organ or target organ damage, the pharmacotherapy should be started early, and the target BP should not be less than 120/70, which is echoing the International Society of Hypertension guidelines, and the target BP should be about 130/80. In Indian guidelines, it is the age limit is 60, whereas you saw in the previous ESH, ACC, it is 65. Here it is below 60, keep 130/80, and 140/90 above 60. Up to 140/90 is reasonable at above 60 years. This is what they talk about. And the International Society of Hypertension, the grade 1, grade 2, and what are the therapies you start. And most important, on the left-hand side, if you see, quit smoking, stop smoking, regular exercise, lose weight, salt reduction, healthy diet and drink, and low alcohol intake. This is something which all of us should emphasize, spend a little more time, apart from initiating on the right-hand side, which most of us tend to do it for most of our patients without looking at the basic culprits, which can be your smoking or lack of exercise or obesity, which most of us tend to neglect or oversee and do not spend enough time to educate our patients to talk about the risk factors and the advantages of weight loss and quitting smoking, etc. Now, what are the new ESH 2023 BP targets and the level of evidence and the class? I have told here in the green bars, it is class 1 evidence, where 18 to 64, again, the same age group, keep it below 130/80, but not below 120/70. patients with 65 to 80 years, the BP should be below 140/80, and in few groups where they reach below 140/80, you target 130/80. The same age group with the ISH, isolated systolic hypertension, the primary goal of treatment to lower systolic BP would be 140 to 150, level 1 class 1 level A evidence. And reduction of systolic BP between 130 to 140 range may be considered if well tolerated. And of course, you need to be not bringing down below 70. Above 80 years, very elderly, would say 140 to 150 is enough to bring it down to that range, and diastolic below 80, but not below 120/70. So essentially, all guidelines recommend 3 months follow-up, BP monitoring, lifestyle intervention, and then initiate. Both ESC, ESH, and Indian guidelines recommend target BP of 130/80 for below 60 years and 140/90 above 60 years. This is the Indian guidelines basically I've taken into consideration, and to keep a target of less than 120/70 should never be attempted. Now, let us move on to the next section, which is the most important section, I would say, that is the non-pharmacological interventions. Again, many of us, including me, many a times we don't spend enough time to enlighten our patients and look at the advantages as per ACC/AHA, the class and the level of evidences. You can see 1A without anything, the weight loss, heart healthy diet, sodium reduction, potassium supplementation, all these are class 1 level A evidences which are there. Especially the DASH diet is something which is given remarkable advantages. Physical activity and cutting down alcohol. And I'm sure at 8:15 in the night, I'm talking about cutting down alcohol. So many of them, our friends may be upset. So this is something where they say standard drinks, 1 drink, 2 drinks, all that. I fail to understand because nobody stops at the end of 1 or 2 drinks. So that is something applicable to both adult men and women. But reduction definitely has got a level 1 class A recommendation, which is there. And look at the best proven non-pharmacological intervention for both prevention and treatment of hypertension. That's something important. The primary prevention and the secondary prevention, that is treatment also. The weight loss, the weight or body fat, and look at the expected 1 kg reduction is equal to 1 millimeter of BP reduction. And approximate impact, when you translate this, on hypertension would be 5 millimeters, patient who's on 5 millimeters. And if somebody is a normal person, it can reduce up to 2 to 3 millimeters of mercury just by 1 kilo weight loss. So that's something, keep your ideal body weight. That's something which most of us, sad part, many of the doctors do not keep themselves healthy. And this is where we need to have our role as a primary prevention. And DASH diet, of course, rich in fruits, vegetables, whole grains, low fat, which is again very fixed in most of our lower middle class or middle class families. The fixed diet, which is very easy to titrate, we need to spend, counsel, and spend. If he is hypertensive, he can lose 11 millimeters of mercury. In normal person can lose up to 3 millimeters with the DASH diet. Sodium restriction less than 1,500 milligrams, again 5 to 6, which I think today there is in Times of India. The average, they have done a cross-sectional study, 8 grams is what people are consuming in India. And people who are obese and smoker incidentally consume about 2-3 grams more than that 8 grams average Indian sodium consumption. Enhanced intake of dietary potassium also would bring down. That is something which we should remember. And the most important bit our Dr. N.K. Singh is also very fond of is about the exercise and its advantages. Look at the aerobic, simple aerobic, 90 to 150 minutes per week can bring down 8 millimeters, say roughly about 5 to 8 millimeters of hypertension patient and 2 to 4 millimeters in a normal person. And dynamic resistance exercises of same duration of 150 minutes per week can bring down to 4 mm of mercury. And isometric exercises can bring down 5 mm. And if you are non-alcoholic, it can easily bring down to 4 mm. That is something they say men less than 2 drinks daily and women less than 1 drink. I cannot, I'm not an expert in this. I still cannot understand that, to be frank. How do they limit 2 drinks and what is that quantity, all that. But to bring down BP, definitely it helps people who are alcoholics to reduce if they limit themselves. This is what is the evidence, what they talk about. And of course, again, I'm emphasizing the ESH, ESC guidelines, where the recommendation is to restrict alcohol and of course to maintain the ideal body weight. And the BMI is something 20 to 25. Waist circumference, they've talked about 94 and 80 centimeters, male and female. And all these are class 1 level A evidences, whether it is alcohol limiting, binge drinking, increased consumption of fresh fruits, fish, nuts, unsaturated fatty acids, aerobic exercises, And most important, the last, you can see the smoking cessation is again class 1 recommendation, of course, level B, but class 1 recommendation, which is there, evidence is there very clearly. So let us end with emphasizing about ESH guidelines quickly. These are the salient features of the ESH 2023, which are what? Salt substitute, increased potassium, strengthening exercises, reduce stress, and of course, more stringent recommendations with regard to alcohol. They have come out that alcohol should not be recommended for CVD prevention, which they're saying. And hypertensive patients consuming alcohol more than 3 drinks per day should reduce alcohol and close to abstinence. That is something which I was talking about, and excessive binge drinking to be avoided. So essentially, all guidelines recommend the weight loss, physical activity, limit in smoking and drinking, salt restriction, consumption of fruits and vegetables to reduce the blood pressure. That's something all guidelines talk about. Finally, the drug therapy, the ESH, ESC, I'm sure all of you are aware about that. Now they are pushing about the dual combinations, the fixed dose combinations are pushed. ACRBs are a must with CCB or a diuretic. And stage 2 triple drugs, you can straight away go to with ACRB, CCB plus diuretic, and resistant hypertension, spironolactone. Beta blockers have got a niche in these guidelines where the heart failure, angina, post-MI, AF, etc., where or a young woman where you can look at the beta blockers. Now, hypertension associated with diabetes, it doesn't change. It's almost same. And the Indian guidelines, which talk about younger and older, they talk about the young and old is 60 years here, and 55 years in this chart, but earlier they said it's 60 years. And step 1 is A, or next step would be A and CRD. I'm sure all of you are understanding what is A and CRD. ACE inhibitors, calcium channel, and a diuretic. Follow-up. Once you initiate, look at the goals, and every 3 months and every 6 months where you need to follow up if there is a high risk, and medium or low risk every 6 months. But within 3 months, you need to bring down the target, bring it to the target, near target, most of the patients. If there is a significant side effects, you up titrate, down titrate, change, etc. The new ESH guidelines revolves around, again, these 4 classes, that is beta blockers, the CCBs, the ASRARBs, and the diuretics. And this is what the drug classes for BP lowering therapy as per ESH 2023, where step 1 is again the FDCs are recommended. ASARBs plus CCBs are a diuretic. Up to 60% of them literally get control. That is what they say in the next 3 months. And if they don't, with triple drug, 90% of them control. This is true. I've seen in practice also. And initiate up titration is something which most of us have an inertia to up titrate the doses, or to add the 3rd or a 4th drug. Please do not hesitate. And that's something which, again, I'm emphasizing that bringing down the BP will give better advantages to our patients rather than bringing down or chasing A1Cs. And of course, true resistant hypertension, which amounts to about 5% of individuals. Sorry. They have told about the reappraisal of beta blockers. It should be used as guidelines-directed medical therapy in respective conditions. That niche which I was talking about can be added at any step. And this is something very, very important even in the Indian context, because our baseline heart rate is definitely sympathetic overactivity is much higher in the Indian context. Drug classes, again, with the CKD stage 1 to 3, CKD stage 4 to 5, that is EGFR less than 30, EGFR more than 30, below 60, ACRB, diuretics, again, they have told about the loop diuretics, and true resistant hypertension, spironolactone, beta blocker, alpha-1 blockers are centrally acting, which you can choose. And SGLT2 and finerenone should be used according to their approval for CKD treatment. Finerenone, again, word of caution, do not combine with the MRA. And this is the choice of initial medications, irrespective. All the guidelines talk about ACRBs and CCBs, and then diuretics in that order. And confirmation, of course, these are the highlights or notable changes in the ESH 2023 we picked up. Confirmation of the definition and classification, upgrading out-of-office BP, encouraging, that is something important. Systolic BP, keep it between 120, 140, diastolic 70 to 80. Physical activity, exercise, lack of these, they've emphasized the role of physical activity and exercise. And of course, the dietary changes and avoiding smoking and alcohol is something, again, they've told. Combination drug therapy, they have told. Up titrate to maximum tolerated, once a day preferred combinations, and preferably they mentioned in the mornings. Further drugs, you can SOS add, and SPCs is something at any step you need to look at them. Preferred use of RAS blockers, as I said earlier. Inclusion of beta blockers among major antihypertensive drugs. They have brought back this. That's something very important. And of course, they have clearly told about positioning the newer class of drugs, the SGLT2 and the non-steroidal MRS. And novel treatment algorithm, including the use of renal denervation also they have mentioned. can be considered as an additional therapy with a true resistant hypertension and eGFR of 40 ml and above. That is something which you should look at. There's a choice mentioned earlier, it had disappeared. Now again, it has come back. And novel treatment algorithm for specific conditions they mentioned in the ESH guidelines, but this is out of scope of this. So that is why this is not covered. The heart failure, CAD, AF, CKD, etc. They have told specially. So essentially, all major guidelines recommend the use of ASR, ARBs, CCBs or diuretics for the treatment. Dual combinations, FDCs are usually recommended. So to take away the key messages, out of office BP measurement is what is encouraged. That is the rule today, and lower blood pressure levels and treatment goals for elderly patients, and simplified drug treatment algorithms with the combination drugs is what everybody are recommending. Beta blockers have again come back and can be used in special situations and as per the patient's requirement. Target blood pressure thresholds for treated patients to help define the recommended blood pressure targets and lower the safety boundaries for treated patients as per their age and comorbidities you should look at. And of course, even after starting pharmacological therapy, please emphasize strictly on the lifestyle changes which is needed throughout their treatment period. So thank you very much for patient hearing. Any questions, comments, I'll be very happy to take it up.
Yeah, comment from Dr. Sangram. I think this was a very, very illuminating talk by Professor Murthy, and I think he has explained everything in so nice way and in very simple way that it all will be benefited. So your comments, and then you take what are the questions in the chat box.
Yeah, thank you, Dr. N.K. Singh and other. Dr. Sreenivasamurthy has covered extensively, covering all the guidelines. As a practical man, what we emphasize is we look at the individual patient guidelines. For example, one patient may not be suitable for other guidelines, like so, and the approach should be a patient-centric, like, and the triad of patients' personal guidelines should be taken into account. So, what is important is some basic guidelines for examination of patients of blood pressure, because we have seen in so many hospitals, we have seen some nursing staff will be taking the blood pressure. At least once in our lifetime, we have to measure blood pressure by ourselves, so that it may become a dictum, so that we can monitor the blood pressure and we can surely say that this patient has got a definite blood pressure. That is one comment. The other thing being the methodology of examination. As we know, clinical is the art of medicine. So before going for any further things, art of clinical examination, measure the blood pressure in both upper and lower limbs, all the four limbs, palpate the arteries, palpate the peripheral vessels, at least once in the lifetime. Before going for a proper examination of a cardia, we call it as a peripheral circulatory tour. So at least once we have to palpate the radial, popliteal, dorsalis pedis, and don't forget to do a good clinical examination, then come back for clinical examination. And all the basics methodology of examination of blood pressure, like positioning, how the patient should be, cross leg should not be there, patient's measurement of BP, all those things should be taken care. And individual patient-centric approach is important, because all these guidelines are there for us to guide. But every patient cannot be fit into that guidelines. So we should have an individual guidelines. This, whether patient's brother or a sister may not fit into this guidelines or that guidelines. So all these guidelines are there for us to help. So whichever patient requires, that we have to take care for that patients for the better control. And again, being the non-pharmacological is one important thing, lifestyle modification. The line of treatment nowadays, 50% of patients should be better with lifestyle modification itself, like all yoga, meditation, drug therapy, everything has been covered by Dr. Sreenivasamurthy, and many things have been told by Dr. N.K. Singh about the exercise and all those things. So priorities for lifestyle modification, classify the patient where it fits, see that what sort of patient this patient fits in, whether it is a essential or a diastolic or a systolic or what sort of, and one thing which was not touched was like the earlier JNC 7 or 8, all those things to be taken into account before we go for further evaluation and management of the patient. Thank you.
Dr. Noni, your comment?
Excellent talk, excellent coverage of the guidelines, and came to know so many new things. Actually, the new things what the doctor has stressed on the ESC 2023, and if I repeat those, actually the diastolic hypertension is stress, and that is important. We have to keep in mind that should be targeted probably, and the treatment protocol protocol, how go to treatment protocol to be done, and that we get to see. And one more important thing, ESC 2020 guideline has said that BP should not be less than 120. That is also important. Again, having a diabetes with CKD3 directly puts into the grade 3 or stage 2 hypertension. And the cardiovascular disease with CKD 4 and 5, you directly put in stage 3. I think this is a very important ESC guidelines. And we also know that targeting this, the treatment outcome. And this, I feel it is very quite logical. And the rest part, Dr. has covered everything. So I'm not repeating all those things. And the most important thing, what has been stressed, the beta blocker. So beta blocker in Indian context is also an important issue, and what is already stressed. I think it's a nice coverage, and BP target end of the day we will be able to know that 140 below 140 is always wiser, and below and 130 in the younger populations. And these guidelines, apart from the special situations of there, and because of shortage of time, probably Dr. Sreenivasamurthy sir has not covered, and how to investigate, and the common investigators highlighted. I think is excellent, and we get a lot of new messages from there.
Dr. Sangram, I think in the chat box there are lots of very interesting questions. So can you please take one by one?
Yeah, sure.
I think you can see that. One is your take on atherosclerotic cardiovascular disease risk estimation in comparison to the ones recommended by the guidelines. So, and very important risk assessment in younger individuals. How can we go about it, as majority studies? Risk calculators focus on the older population. I think this is very interesting. Dr. Sreenivasamurthy.
Yes, sir. I think the risk stratification to be done across the spectrum of age group. There is nothing that you need to take it up only for 60 or 50 years. Anybody, especially in youngsters, we need to look at the secondary hypertension causes. The drug substance abuse is something which is to be kept in mind, especially in the younger age group. That is something which we have to do. And the assessment, everything remains same across the age group. There is nothing that you need to do it only for 60 years or only for 40, 30. There's nothing like that. So across the spectrum, risk stratification, and as I said, diabetes, just being presence of diabetes itself pushes them to a high risk. So irrespective of their status of A1C, the dyslipidemia or other comorbidities, any diabetic who walks in, the BP part has to be taken care very stringently. So risk stratification, that's the answer, that it remains across the spectrum of age group.
Only thing I think the American College of Cardiology says that most of the guidelines, when they did they generated these guidelines, that things were done in the older age group. That's why a big problem. So many say that if it is less than 40, don't go with this specified guidelines, which these guidelines say, like a score 2, a score 3, or Q risk, or whatever it may be. But anyway, this is very important point you told, that these days, even in all the younger patients, the risk calculation should be done. Maybe you can do by something other things. You can have some other things to do, like today these days the calcium, coronary calcium artery
Scoring,
that scoring is have become very important, and that should be definitely done. And all those factors, our young generation is all getting have dyslipidemia, smoking. I think most of the smokers are younger. So I think these all things should be taken care of. The lipids should be taken care of, and whatever you risk profiling you told that should be done. So I think definitely this is the answer. I think you told that already.
Yes, sir. I think there is one more, sir, question related similarly. Do you agree, sir, the risk estimation is underestimated in the younger subjects due to which lesser preventive strategies are implemented in them, leading to problems in later stages of life? I think that's a very pertinent question. Dr. Noni, what do you think?
No, the risk estimation already have mentioned on this side, because it is important for our management also. And one of the slide you have already mentioned that the 10 years ASCPD below 5, what way you go to manage the patient below 5 to 10, above 10. This is also guide, like our giving a direction towards the treatment, how aggressive we're going to go, how to start. So it is very much important. And regarding the point is, as we agree that estrogen is less done. In fact, in India, our 50% hypertension are undetected. So less stratification comes next. So first is the awareness regarding hypertension. So this much of treatment, and most of us are not aware of the guidelines, how we to proceed, how we to investigate, and that is also most important. If you do this stratification also, and if you do not properly go the guidelines, and if you properly do not investigate, and you do not get the target, so you are not preventing the disease actually. And in the data that only 20 to 25% are really getting the target. So that also long way to go. We got to achieve, and we have to be aggressive. And we have already mentioned that once your BP is more than the stage 2, 160 and 110, we got to start at least dual and antihypertensive. And that has also been quite less seen. And there is a conservative from the doctor's side that they start with only one, they wait for 3 months. I think that also be important. So all are important. And definitely, yes, risk assessment one should do. And see, even hardly we see the EAGF for written in the prescription. Once the lab should give a EAGF, once you put a serum creatinine, you should have EAGF. You should have idea like what exactly doing. And regarding the albumin and proteinuria, so many things. Albumin and the single shot fast visit is there. We will take up or not. How we go to repeat? We should repeat after 3 months with proper precautions. We are getting a serum creatinine in one shot. Actually, there may be a lot of other causes. We got to repeat. So many points are there. So all are important.
Yeah, so Dr. Sangram, how do you tackle? Suppose a patient of 55 years age comes to you with hypertension, new onset hypertension, a 30 years old coming with hypertension. So do you go for all these risk profiling in both?
Yeah, I prefer what we should be preferred. It should be a multidisciplinary approach, like check for the lipids, the renal function, the cardia, the obesity, the BMI. Yeah, patient as a whole, we should think of all the other things because most of the things are reversible. Lifestyle modification itself is a main thing. So do a systematic approach, record the blood pressure, stratify the things, whether what sort of dipping, whether ambulatory or home blood pressure or whatever it is, before we start any medical line of treatment. I want to emphasize on all the aspects to be taken care. How is his lipid? What is his thyroid for status? What is his metabolic status? What are the renal functions? Obesity, BMI, all those things to be tackled and taken into account. Then start the lifestyle modification, aggressive lifestyle modification. Wait for some days. Then do recheck the blood pressure by all, whether it is in office, out of office, or an ambulatory. See for are there any dippings, night dips are there, or day dips are there. So make sure that we are dealing properly with and label him as an hypertension, whether it is an isolated or a diastolic or an essential. Then make him to see that we start a good therapy of combination so that his blood pressures are controlled very well. So look for any target organ damage like the fundus, the renal, the cardia. So all the basic baseline work is very important for all young individuals before we go on and labeling and bombarding with the drugs, whether what sort of drug, a single or a multiple or a combination. So make sure that patient has got a multidisciplinary approach. Look for his parameters carefully, then go for pharmacological therapy.
So I think we have got 3 more questions. One is the opinion on this reintroduction of beta blockers in the latest EFH guidelines. So Dr. Murthy, what do you think? Why they have reintroduced it? Or given a much importance for that?
Yeah, I think they have realized the mistake, sir, because in Indian context, especially I was talking about, I do not know the incidence of sympathetic overactivity in the West, but Indian context, definitely it is there. The sympathetic overdrive has got a huge role. I have been using them, especially highly selective beta blockers. And I was surprised the last 2-3 guidelines were not talking about earlier. But I'm very happy that they have come back. And that's something welcome, especially in the Indian context, I would say.
Yeah, that's the reason I think very important. The second thing that you told about the translation of new drug classes like SGLT2 inhibitors and non-steroidal MRH into clinical practice. So again, this is a very important thing which is coming up. So suppose for SGLT2, what are the indications in the hypertensive cases? Now suppose a non-diabetic hypertensive case, is there any role of SGLT2 inhibitors there?
No, so far the SGLT2s are not been indicated as antihypertensive. That is very clearly mentioned, though up to about 6 mm or 7 mm systolic blood pressure reduction is seen. But what I've seen in clinical practice, sir, is weight loss induced by this SGLT2 group will translate into the control of BP. That's a wonderful pleiotropic effect of SGLT2 when it comes to the hypertension, because 2-3 drugs invariably I have brought it down to a single class of drug, especially the diuretics are withdrawn in many of the patients when SGLT2s are initiated.
So I think again this drug, the non-steroidal MRI epinephrine, very emerging very fast in our clinical practice. And although we have seen many prescriptions where they have written that was blender, they have done blender by using this drug. So I think when the epinephrine should be used, it is a very costly drug at present.
Yes.
So what is the real position in your clinical practice at present?
I think SGLT2 failure, patients who cannot tolerate contraindications and with the associated hypertension comorbidities, where I've used with the eGFR cutoff also. That is another point we need to look at when the SGLT2s cannot be placed in that.
Yeah, so I think for renal protection it is very important.
Yes.
So in those cases you should consider this. And you also talked about, already you told the answer when it comes to renal denervation, which profiles should be maximum benefit. I think already you have showed it.
Yes.
You told about that
resistant hypertension.
Yeah, resistant hypertension.
Failure.
Far more than 40 you told.
Yes, sir.
And uncontrolled blood pressure. Despite the use of so many antihypertensive. I think the scenario at present. So I think these guidelines have recently, I think they've given importance to this again. So
correct, sir.
Important, yeah. So I think these are very 4 or 5 very important questions. Already our time is over. So Dr. Snehal, what to do? You can tell.
Yes, sir. So there are no more further questions from the audiences, sir. My heartfelt thanks to Singh sir, Murthy sir, Noni sir, and also Biradar sir. It was wonderful having such an extremely talented panel of all you doctors on board today, sir. The audiences have also appreciated the session very much, and all the insights shared from this excellent discussion today will be of an help to all of us. Thank you very much once again, Dr. Singh sir, Dr. Murthy sir, Dr. Noni sir, and Dr. Sangram sir for giving us your time today. It was wonderful having you on board. With this, we sign off now, and I would like to thank the audiences as well for your active participation. Thank you once again.
Yeah, thank you very much. Thank you.
Thank you, everyone. Thank you.
And thank you,
Thank you.
also. Thank you.